So today's talk will be looking at cryptorchidism. So just first starting off with some definitions. So we know cryptorchidism is defined as failure of the testes to descend into a scrotal position. And typically this normal scrotal position is defined as when the midpoint of the testicle is within the midpoint of the scrotum. There's also a phenomenon called an ascending testes or an acquired cryptorchidism. It's basically a previously intrascrotal testicle that subsequently ascends afterwards. And so in terms of the physiology of normal testicular descent, it really happens over two phases. So you have your transabdominal descent and your inguinal scrotal descent. So transabdominal typically happens between 8 and 15 weeks gestational age. And in terms of the studies, they basically say that there's a swelling and a straightening of the distal gubernaculum, and that's assisted by this insulin-like 3 peptide. And you also get regression of the cranial suspensory ligament attached to the top part of the testicle. And this is followed by the inguinal scrotal phase, where the testes comes down to the internal ring, and that's about 22 to 25 weeks gestational age. Afterwards, which the gubernaculum comes over the pubic ramus and comes down to the scrotum. So there's all these androgens that are released along the genitofemoral nerve and also transmitters which help with this process. And essentially, you also get a fold of peritoneum developing within the gubernaculum, and that's your future processus vaginalis. In terms of anatomic classification for cryptorchid testes, it can lie typically anywhere between the kidney and the scrotum. And in terms of the new updated AUA guidelines, 70% of these are noted to be palpable and 30% are non-palpable. And of the ones that are non-palpable, about a third are in the inguinal scrotal canal, a half are truly intra-abdominal, and about 15% are absent or vanishing. Surprisingly, it is one of the most common congenital anomalies, but the true prevalence of cryptorchidism is actually quite difficult to determine. And the reason for this is because there's a lot of subjectivity and differences in terms of inter-observer examination. And the definition of cryptorchidism can be quite different amongst different epidemiologic studies. So some studies will include a high scrotal testes and others will not. And there's also kind of differences in terms of the study population and the study design itself. The overall rate, though, reported in the literature typically is about 3 to 5% for newborns, and this decreases to about 1 or 2% after 3 months of age because they do have some spontaneous descent that happens. In terms of the phenomenon of acquired cryptorchidism, it is really difficult to appreciate, a true acquired testicle versus a missed congenital cryptorchid testes. And so a small proportion of non-cryptorchid patients will actually become cryptorchid. And they state that this prevalence is about 1 to 7% of all cryptorchid testes, and it peaks at about 8 years of age. Things to watch out for if the patient has hypospadias, retractile testes, or contralateral cryptorchidism. These have been associated with higher incidence of subsequent acquired cryptorchid testes. Now, in terms of the risk factors for what predisposes patients to cryptorchid testes, so it typically is multifactorial. There are syndromic associations, things where you have decreased androgen production or androgen action, such as androgen sensitivity syndrome, or MSK defects if your abdominal wall, like prune belly syndrome. There is a genetic susceptibility, so this population study looking at a Danish population found a very high concordance rate amongst family members. So in unrelated males, there's about a 1.8% concordance rate, but 7.5% in full brothers, and this increases for dizygotic twins at 17% and 27% for monozygotic twins. There's a lot of different genes that are implicated in this association, but weak evidence providing support for one specific gene. Other perinatal factors include low birth weight, being small for gestational age, premature babies, and then babies with breech presentation or maternal diabetes present in the pregnancy. So in terms of the gestational age, there's actually a 15 to 30% prevalence of cryptorchid testes amongst premature infants. And the other association with low birth weight, so the prevalence actually decreases when you have increasing birth weight. So very small babies, less than 900 grams, there's almost 100% concordance with cryptorchid testes. And that's probably just because they're in that phase at gestational age where the testicle is still descending. So in terms of environmental exposure, there is this ongoing debate about how environmental chemicals can change the reproductive tract development. There are different endocrine disrupting chemicals that have been linked to these reproductive tract anomalies, but it's still inconclusive from all the epidemiologic data that they have. There's no real association in terms of BMI, smoking status, or alcohol status of the mother. In terms of estrogen or pesticide exposure, the new guidelines say that you can't really rule it out. And in terms of analgesic exposure, there is a trend in terms of higher rates of cryptorchid testes with analgesic use. And so, for example, COX inhibitors with prostaglandins, we know that prostaglandins are very important for male sexual differentiation, and so you get inhibition of that pathway. When you're diagnosing cryptorchid testes, the most important distinction really is it a palpable testicle or a non-palpable testicle? So things to elicit, on history for medical students, so gestational age of the infant, birth weight, any previous maternal or exogenous hormone exposures. Were these testes ever palpable, and have they ever had previous inguinal surgery? And is there a family history of undescended testicles, precocious puberty, infertility, or consanguinity? Things to elicit on physical exam, you want to know, is the testicle palpable? What is the position of it? Is it mobile, not mobile? How big is it? Any other associated findings like hernias, hydroceles, hypospadias, penile size? We should really be documenting the lowest position of the testicle that we can attain when we examine them. And then in terms of retractile or true undescended testicles, you want to bring that testicle into the hemiscrotum, tire out the cremasteric muscle, and see if it stays within the scrotal sac. If there is a contralateral hypertrophy in a non-palpable testicle, then this is associated actually with monorrhea. So the new guidelines do say that a general exam should be performed as part of every well-child check, and because of the risk of an acquired cryptorchid testes. If you do have a non-palpable testicle, then there's really three possibilities. So it can either be an abdominal testicle, it can be a complete atrophied or vanishing testes syndrome, and for that diagnosis, really during time of exploration or whatnot, you should see and confirm blind ending spermatic vessels. And it's likely secondary to some torsion event that happened after the testicle developed, but previous to the descent of the testicle. The other possibility is that it's just extra-abdominal and not palpable because of whatever cause, like habitus of patient and patient cooperation. So are there any laboratory investigations that are warranted when you're working up a child? Yes. So if you have any basically testes that are non-palpable associated with hypospadias, or you have bilateral non-palpable testes, then they should all get a karyotype, as well as electrolytes and 17-hydroxylase progesterone levels to rule out CAH or congenital adrenal hyperplasia. If you want to know if there are any testes present, there are some tests you can do. So in infants less than 3 months of age, testosterone levels, FH, LSH levels can be done, or greater than 3 months, you can do a beta-HCG stimulation test, you typically, if there's no rise in your testosterone, then you can diagnose anorexia. So really, is there any utility for imaging? So imaging modalities are present. Factors that influence your decision of whether or not you're going to image testicles, you have to look into cost considerations and then the true accuracy of these tests. There's a lot of false positives, and then also for MRIs or MRAs, which have been described, there's anesthetic requirements for this, right? So ultrasound is the most widely used diagnostic test, and in this systematic review and meta-analysis done in 2011, they looked at about 700 non-palpable testes, and they basically computed what the sensitivity and specificity amongst all ultrasound in localizing this cryptorchid testes, and they compared it to the gold standard, which was the location of the testes at time of surgery. And what they found was that amongst all comers in all of their non-palpable testes, there's quite a low sensitivity specificity, and you can see that the sensitivities are quite low amongst all of the three categories there. So these authors concluded that ultrasound was poor for localizing non-palpable testes, and one thing that they did find was it was really hard to differentiate between non-viable nubbin tissue and surrounding inguinal tissue. They also found that the bowel gas made it difficult to locate the intra-abdominal testicles. So really in the new guidelines they state that there's no imaging test that can truly conclude a testicle is absent with 100% accuracy anyways, and because of that we should proceed with surgical exploration. So the following are some Canadian studies looking at this. So this is a group out in Hamilton, McMaster, and this was published in CUA last year. And basically what they did was they looked at about 230 patients that had cryptorchid testes, and about 60% of them did have an ultrasound done. And so then they compared basically the referring physician's diagnosis of cryptorchid testes and compared that to the pediatric urologist, and that they found there was only about a 39% agreement amongst the two. And then they also found that in terms of ultrasound findings compared with the pediatric urologist phys exam, again, very low concordance rate, 38%. So what they did find was there's a difference between the diagnosis for referring physician and urologist, and also the ultrasound didn't really change the referral patterns at all. What about costs? So this other group looked at also unilateral cryptorchid testes, and basically looked at 360 patients, and of those about 50% of them had an ultrasound before they saw the pediatric urologist, and this actually led to a cost estimation of about $30,000 in terms of the referrals from physicians that were GPs or pediatricians to the urologist. There was no difference in terms of ultrasound ordering preference. What they did find was there was a significant time delay from the referral that the referral was made to the urologist assessment if the patient came with an ultrasound as opposed to without an ultrasound, and then the time from referral to surgery was actually also delayed. So in conclusion, ultrasound costly and also delays time for definitive treatment. So now moving on, why do we treat cryptorchidism? Why is it important? So some of the things stated include malignancy risk, infertility, high risk of testicular torsion, as well as some trauma against the pubic bone that can happen. In terms of malignancy, so the malignancy rate for cryptorchid testes is stated to be about 1 in 500, and this malignancy risk is actually a lot higher compared to normal testes. Within that group, abdominal cryptorchid testes are at even higher malignancy risk. And so right now it's unknown whether or not these two, it's because there's an association between cryptorchidism and testicular cancer that they share in common, or if there's actually a cause between cryptorchidism leading to higher risk of testicular cancer. So now that begs the question of when should these cryptorchid testes be treated to lower the malignancy risk? And so Patterson's group looked at this in 2007, and basically they looked at all men in Sweden that had undergone orchidopexy for cryptorchid testes, kind of between the 60s to 2000, and they followed about they had 17,000 men, followed for about 200,000 person years. And basically they only included men that had orchidopexy done at less than 20 years of age. And their reasoning for that was to reduce the selection bias in patients that were seeking treatment for fertility improvement or whatnot. And so they followed these patients from 15 years of age onwards, or the date of orchidopexy, until the diagnosis of either testicular cancer, or they reached 55 years of age, or they left or died or ended the study. And they did find 56 cases of testicular cancer. And so looking at this, basically what I want to highlight was the standardized incidence ratio, basically looking at the incidences of testicular cancer within the this cohort of cryptorchid testes compared to the general population, which they use as the Swedish general population. If they were 13 years of age or under at time of treatment, then there was a higher incidence ratio of 2.2, but if they were treated after puberty, then that went up to 5.4. So age of orchidopexy really does have an effect on the risk of subsequent testicular cancer for cryptorchid testes. And again, after puberty, this risk of testicular cancer seems to be twice compared to those treated at a younger age. Now, what is important to note regarding this study was that there was no information regarding the location of the original cryptorchid testes. And so overall, though, it doesn't matter what the age of treatment, the risk of malignancy really doesn't go back to baseline for these patients. Moving onwards to infertility now. So basically looking at causes of infertility in this population appears to come from maldevelopment of the testes. Seems to be that there is kind of an improper environment for the normal testicular growth. There's increased temperature surrounding the testicle, and then there can be increased pressures within the spermatic cord in the canal that compress and affect blood supply. Is there a difference between unilateral and bilateral cryptorchidism, and did they actually find any differences in terms of the semen parameters for these patients? There's been lots of papers looking at this, and so this group basically looked at about 70 men that had previous history of either unilateral or bilateral orchidopexy, and they looked at them between the age of 25 to 30. About 2/3 were unilateral and 1/3 was bilateral cryptorchid testes. Average age of orchidopexy ranged between 2 and 12 years. Basically, at time of the study, 90% of the patients did not have any children yet, but obviously there was quite a young age group still, 25 to 30. And then 30% of those, though, had attempted to father children for more than 12 years. And they found that patients essentially with bilateral orchidopexy had decreased sperm production concentration, decreased sperm motility, inhibin B levels, and testicular volume. And so in that analysis, they found that patients that had bilateral orchidopexy had poor fertility prognosis compared to those with unilateral undescended testicles. And then within the unilateral group, though, they looked at the semen parameters and found that if they were treated younger, they had better fertility prognosis compared to older patients in terms of those factors, though, sperm concentration, motility, and testicular volume. So what about the location of the undescended testicle? So this was kind of an interesting study looking at the paternity percentages and hormone levels, and then correlating that to the actual testicular location. So they found that in terms of the fertility rates and the hormone levels, they compared those and compared it to testicular location. So paternity and then duration of the attempted conception, sperm counts, and hormone levels. Basically, they found that all of these factors did not change based on whether or not where the location of the testicle was before surgery. They found that actually the overall paternity rate was 90%, and the lowest rate was kind of 83% within their abdominal group, and so there was no statistic difference in that value and those differences. And so they concluded that really if you have unilateral cryptorchidism, the preoperative testicular location didn't really affect fertility in terms of paternity, sperm count, or hormone levels. So looking now, in terms of overall in conclusion then, for malignancy and infertility, for malignancy, it's better to have prepubertal orchidopexy to lower your malignancy risk. And the infertility, basically when you define it in terms of semen parameters, hormonal measurements, it appears to be that if you fix it the earlier, the better it is. So how do you fix cryptorchid testes? So there's hormonal therapies and surgery. The hormonal treatment is something that has been stated to be used quite widely in the literature, and there's three main uses for hormone therapy. So one is you're actually stimulating testicular descent. You can try to enhance germ cell maturation, and then some people even have used it to kind of differentiate between retractile or true cryptorchidism. And so the thinking is if you just have a retractile testes, it's much easier to bring down into the scrotum. So this hormonal treatments are quite popular in Europe, and obviously it helps to stimulate production of androgens within your Leydig cells. Now, the basis for this is that there is a hypothesis that basically male infants at about 3 months of age will have some surge in their hormonal levels, and this is blunted in cryptorchid testes, and so you don't get the full germ cell maturation process happening that normally does happen. HCG, so it's not without its own side effects. You get increased scrotal rugae, pubic hair, penile growth, premature epiphyseal plate fusion, which subsequently leads to stunted somatic growth, and also low success rates, which they found. LHRH, very similarly, has also side effects from the increased androgens, and again, so increased penile testicular size, scrotal erythema, erections, and again, low success rates of treatment. So is there really any evidence that hormonal treatment works? Most studies nowadays will concur that basically if you're trying to use hormonal therapy to stimulate testicular descent, you shouldn't use it because it's effective in only about 20% of cases that they found, and there's a 15% rate of reascent when you stop hormonal therapy. So what about these other rules for hormonal therapy use? What about improving fertility, for example? So this was a paper looking at neoadjuvant GnRH therapy before surgery, and then looking at basically what happens to the fertility index in unilateral cryptorchid testes. So we looked at 24 patients, basically wide range of age groups, so age 12 to 120 months, and they looked at unilateral cryptorchid testes only, and they were all intracanalicular, so they looked at based on location of the testicle, and they randomized them to 2 groups, so GnRH for 4 weeks and then orchidopexy or orchidopexy only. They all underwent testicular biopsy at time of orchidopexy, and so they did exclude all these other criteria that might affect their conclusions, like bilateral disease, retractile testes, previous other surgery, premature babies, and they basically counted the total number of seminiferous tubules that they saw, as well as the number of spermatogonia, so your dark spermatogonia. So these are your progenitor cells, and they basically keep reproducing to continue having production of spermatogonia, which subsequently some of them become your primary spermatocytes, but not this progenitor population. So their measurement of fertility index, they basically calculated as number of spermatogonia per tubule, and those that had GnRH treatment pre-orchidopexy had a higher rate index compared to those that only underwent orchidopexy. When they did their calculations, though, they found that there was really only a statistically significant difference in fertility index for patients that were a little bit older, so 3 years of age or older. And so they came to the conclusion, though, that neoadjuvant GnRH does improve the fertility index for these types of scenarios. So in terms of the literature, though, this interesting papers published subsequent to that looked at all of these controversies, and they did actually a pretty good review of the literature. So they looked at 3 different hypotheses. So the first hypothesis they looked at was that cryptorchid testes is an endocrinopathy. And so after examining all the papers, they came to the agreement or conclusion that the pathogenesis is multifactorial. And then the second hypothesis they looked at was that hormonal replacement typically corrects the endocrinopathy. So they kind of made reference to the previous paper and stated that GnRH agonists will increase the number of spermatogonia or dark spermatogonia, and that is hypothesized to lead to improved fertility. However, really, we don't know what specific histologic changes are responsible for the impaired fertility that you see when you have cryptorchid testes. And also, we don't really know if this increased spermatogonia count, if it's a transient effect or not, and what happens after you stop giving hormonal treatments. So the third hypothesis was that fertility and paternity rates are impaired in unilateral cryptorchidism, and they came to the conclusion that if you have unilateral disease, it's actually quite normal in terms of your paternity potential compared to the general population. So in conclusion, they felt that obviously endocrine factors are important, for stimulating transinguinal testicular descent. And then patients that have undescended testicles, this conversion of your true spermatogonia to your dark spermatogonia in your first couple months is a bit deficient. And the patients that have unilateral undescended testicles, even though they have lower sperm counts, they seemingly have quite normal paternity rates. So overall, there's really lack of any strong evidence for this. There's a lot of costs associated with it and side effects. And so actually the new American and European guidelines both advocate against the use of hormonal therapy. So when we look at surgery like orchidopexy, all the goals of treatment really can be accomplished. So preserving your fertility potential, placing the testes within the scrotum for cosmesis improvement, and then monitoring malignancy as well as repairing any hernias that are present as well. So looking at surgical treatment, the most important decision when you're making your decision is it palpable disease or non-palpable disease. So looking at this, if it's palpable within the inguinal canal, scrotum, or high scrotum, orchidopexy, the timing of orchidopexy should be done between 6 and 18 months, and that's preferable. There's a 2-incision technique or 1-incision technique. We're familiar with this in terms of, in the inguinal incision, we want to try to mobilize spermatic cord, gain some length on it, and then the scrotal incision is made to pexy it into place within the scrotum. There's also a 1-incision technique for lower testicles. Now, if you can't gain enough length using these, you can also try to do a bit of a Prentice maneuver, which is either cutting or ligating the epigastric vessels, so inferior epigastrics, or just transposing the testes underneath them. And that basically, if you think of it in your mind, it just straightens out or shortens the distance that testicle has to travel to come down, as opposed to taking away that bend that happens down here. So when you have a non-palpable testes, you should bring all of these patients in for an EUA. If you find the testicle, then great, you can proceed with orchidopexy. If it's still non-palpable, then I think at that point in time, the laparoscopic or open transabdominal exploration is warranted to kind of look for the testicle, look for any testicular vessels. And once again, I want to reiterate that if you see a vas, it doesn't mean much because the embryologic origin is quite different. And so it doesn't really tell you where that testicle might be. So let's say you find an intra-abdominal testicle and you see it. It's really 3 options, right? So you can undergo primary orchidopexy or a 1- or 2-stage Fowler-Stevens repair. So this Fowler-Stevens orchidopexy, basically, it's done if your testicular vessels are really too short and you're not able to bring the testicle down into the scrotum. You essentially divide the testicular vessels, and so you depend a lot on these collateral blood supplies to the testes, which is given by the vas deferens artery. So in the 1 stage, basically, you do the division and you bring it into the scrotum. In the 2 stage, there's a 3 or 6 month period between dividing the vessel and bringing it down. One interesting point is, where should the point of ligation be when you're doing this procedure? So classically, Fowler-Stevens, they described it as a high ligation. So basically, before, they did not, in terms of the anatomy of the testicle, they understand that there was no, they thought that there was no anastomotic circulation distally between the vas deferens artery and the testicular artery. So they suggested a high ligation where you get collateral supply distally from the vas deferens. This group actually, in I believe 97 or 99, looked at low ligation. And so basically they suggested that if you ligate the testicular vessels as close to the testicle as possible, then you basically get more improved collateral supply superiorly. But if you follow an incision along that dotted line on the right, then that can kind of gain, you can gain actually quite a lot more length in terms of the vas coming down. So they thought that they had better outcomes in their series, but obviously this was quite a small number of patients, and so the overall consensus is still that the technique should be chosen based on surgeon experience and what it looked like at time of surgery. So, you know, the new guidelines state that in terms of overall success rates, quite good. Primary orchidopexy about 96%, one-stage Fowler-Stevens, and two-stage 88%. They do recommend primary orchidopexy as a priority if you're able to do it, and then if you're not able, one or two-stage can be done. In terms of a comparison between one-stage or two-stage, basically it doesn't really seem to be any true difference in terms of the overall success rates and the rates of testicular atrophy, which is a complication of these procedures. This group basically came to the conclusion that there's no real difference in terms of size, blood supply, position, or rate of atrophy for these testicles. So, in terms of recommendations, you know, if you do, whether or not you do a one-stage or a two-stage approach, it should really be based upon the discretion of the surgeon, and then at time of surgery, a decision that's made. So again, for non-palpable testes now. So if the testicles are not identified at time of laparoscopy, so you should look around and see if you can find any testicular vessels. If you have a blind ending testicular vessel, that kind of suggests that this was a vanishing testes. If you see a blind ending vas, though, the testes can still be present in somewhere else. And if you see vessels entering into the internal ring, you should do a groin exploration to see what is there. There are some indications for orchidectomy. So, you know, if you have too short of vas deferens and you can't actually bring the testicle down, really short testicular vessels, a testes that doesn't seem like it's worth salvaging or it looks abnormal, and then post-pubertal males. So let's say at time of abdominal laparoscopy you find a testicular nubbin. So what should you do in that case? So interestingly, this paper did look specifically at testicular nubbins, and so at time of laparoscopy, if they found a nubbin, they would take it out, and they basically did a histologic analysis of them, and they found that actually there's a lot of seminiferous tubules and viable germ cells within those nubbins. So actually 10% of their nubbins that they found had seminiferous tubules, and 5% of them had germ cells. Also, what they found was when they explored the contralateral testicle, 3% of the time they found like a little bit of an ectopic testicular remnant, like that's crossed over from the cryptorchid side. And so these authors suggested that if you see that, you should remove the nubbin and you should do maybe a contralateral orchidopexy. Now, there's really no formal guidelines regarding the management of these testicular nubbins. The literature overall seems to support a practice of orchiectomy, you know, due to some theoretical malignancy risk. However, because there's really no proven increased malignancy risk in these, generally in terms of the local practice, if you have a palpable nubbin before surgery, you know, you can do an exploration and subsequent orchidectomy, but that's only done really to confirm more of a diagnosis in patients that are kind of difficult to examine, so very obese, for example. And then contralateral orchidopexy is not typically done, but because there's really no proof that there's a higher risk of torsion in this population. What about testicular biopsy? Is there any role for biopsy when you look at these patients? So basically, if you're trying to just look at the maturational status of this testicle, then doing an intra-op biopsy is quite controversial, and right now it's really done only for research purposes. A paper or a study published in 2005 did show that it does not seem to be any increased risk of anti-sperm antibody formation, or microlithiasis when you biopsy them. True indications that are still present for biopsy include if you see an ovotestes, you see dysgenesis of the testicle, or you suspect some tumor present. So why should we follow these patients? So basically, even after you do orchidopexy or fixation of the testicle, there is still risk of atrophy, subsequent reascent, and then obviously that malignancy risk that didn't go away. Basically, the reported rates of reascent after orchidopexy are about 2.5%. And if you do have this happening, usually, if you just do a scrotal orchidopexy, it will help to repair these testicles. The Swiss guidelines currently suggest after orchidopexy, you follow these patients at about 1, 6, and then 12 months. And then afterwards, the patients or patients themselves or their parents can take over subsequent examinations. If there is subsequent atrophy, you really don't need to do anything else other than maybe offering prostheses. And so now, looking at retractile testes, what about these retractile testes? What's the risk of them becoming ascending testicles, and how should they be followed? This group by Charles Key looked at specifically retractile testes, and what they found, it's interesting, there's actually 2 peak time periods in terms of orchidopexy incidence. So really young, less than 2 years, or about 10 years of age. And so in terms of testicular ascent, the testicle coming up, the mechanism is not really clear, but they hypothesize that's probably, there's a disproportionate growth between your boy and your spermatic cord. And the cord kind of pulls the testicle into a suprascrotal position. It doesn't elongate properly. There's a fibrous remnant of the process vaginalis just tugs on it, and then maybe you have some tethering of an ectopic gubernaculum. The rate of ascent or acquired cryptorchidism was about 7 to 30%, they found. And the problem, though, was, again, there's a non-uniform definition of retractile testes amongst the different studies. They had different indications for orchidopexy, and then the follow-up periods weren't very long. But overall, though, the current evidence there shows that there's no really any increased malignancy risk in retractile testes and acquired cryptorchidism, and there's no real statements on terms of risk of infertility. There's no real evidence. And so in conclusion, they felt that the risk of an acquired cryptorchid testes developing in a retractile testes wasn't high enough to warrant orchidopexy for all retractile testes comers. And they suggested annual evaluation until after puberty, and then they suggested orchidopexy should be done in cases of subsequent acquired ascent. In following discussions, this seemed to be more of a litigation safe or a very conservative practice in the U.S., and it is still quite controversial whether or not all retractile testes have to be followed until puberty, because again, there's no increased risk of malignancy that's been proven, and sometimes a very small subgroup, though, can be followed if they're kind of in a gray zone, kind of in the zone where you're like, I'm not sure if it's retractile testes or truly as just a suprascrotal cryptorchid testes, and you want to watch them. In terms of adult cryptorchidism, just a couple slides on this. What should be done? Orchidectomy, orchidopexy, or surveillance. Basically, they looked at this, and very interestingly, it was kind of interesting how they looked at this. So basically, they looked at all of the American data on germ cell cancer mortality, and they looked at this for 5-year intervals from age groups 15 to 60. Now this was in 1997, mind you. And then basically they looked at the germ cell mortality risk in cryptorchidism, and they obtained that value by calculating by a factor of 9.7 for every 5-year interval because of the higher risk of cryptorchid testes having malignancy. And then they basically looked at the perioperative mortality data on all comers of patients having general anesthetics in the States. And they compared this mortality data to those that had, and compared it to the risk of death from germ cell cancers. And what they found was that when they compared these groups, if you're a post-pubertal male and you're like 50 years of age or younger, and you're otherwise healthy with ASA 1 or 2, then you probably should have orchidectomy. And then if you're ASA 3 or 4, or you're older age, greater than 50, then probably just watching and waiting and conservative management is the best approach to go. Now, there's again no formal guidelines regarding this topic, but this is the conclusion that these authors had come up with. So, in terms of take-home points, this is all part of the AUA guidelines, the new recommendations. So, general examination should be part of every well child visit, and if you have an undescended testes by about 6 months of age, this does warrant surgical referral. And timing of repair is typically 6 to 18 months. Some post-operative follow-up is important, and we should always counsel patients and parents regarding malignancy risk and infertility factors. And then retractile testes themselves may or may not require ongoing examinations at the discretion of the subsequent treating urologist. Thank you. So I'd like to thank Dr. McGilly for his help with some of the presentation. Thanks.